What's up, guys? I've caught me in a bad time. No, as you've ever thought about using one of these toilets before, don't do it. Okay, this is a toilet inside a patient room. Obviously, there's no patients in here right now. But today I've got a cool video that you can watch. It's going to be a little bit of a review of a lot of stuff. Specifically talking some ER and ICU nurses. We're talking about mechanical ventilation, a little bit of blood gas, a little bit of this, a little bit of that. It's a long one, so strap on because the intro's coming next. So we'll get started. What we'll go over first is just ventilators and kind of like ventilator settings. We'll go with the generic names and then we'll bring in our device that we have. So first thing that you're going to look at with any type of device, there's three main modes, and this may be a review for you, but there's three main modes. And so this is always the first thing that we are going to this is the first thing you're going to give them a report, okay? So they're always looking for, just like with a blood gas where you say the blood gas is 7.25, 55, 95, and 24. That's always pH, CO2, PO2, and bicarb. In this case, whenever you give somebody vent settings, you're always going to say the mode, rate, VT, which is tidal volume. Some people call it TV. That's kind of, I don't like that, whatever. And rate, tidal volume, and FiO2. Does everybody remember what FiO2 stands for?
Is that the peak flow? Or?
No, that you're thinking of TI. So that's inspiratory time. That's good though. I'm glad I'm talking about this. So FiO2 is fraction of inspired oxygen. So in other words, it's the oxygen percentage you're delivering. So how much oxygen is in room air? What percentage?
21%.
Yeah, 21. So the lowest you could get FiO2 is 0.21. Okay, and then what would 50%? It will be 0.5, and then FiO2, it for 100% it's 1.0. We just call it 100%, and we'll say, what's the FiO2? 50%. You really should report it as 0.5 technically, but either one will work. So, all right, FiO2 or the oxygen level. So that's kind of the same thing. So first thing we're going to do when you give a report, you're going to say what mode they're in. The vast majority of the time, your patients are going to be in AC. Does anybody remember what AC stands for? Okay, so that's okay. Assist, control. Assist, control. So exactly like it says, it explains what the machine is doing. It's assisting, but it's also in control. So in this case, you're going to have a set number of breaths per minute, okay? But then the difference is, and we'll show you a little in a schematic in a second, the difference is going to be if the patient takes a spontaneous breath, so let's say they're not totally paralyzed or they're not totally sedated, and you have a respiratory rate set of 16, and in between those they start their breath on their own, the machine finishes it. So finishes every breath. Finishes every breath. So I'll show you in a picture, and it'll make more sense in a second. If anybody asks you, and this is what I tell families, if your patient's in assist control, which in the ER usually they're going to be because we've either sedated and paralyzed them, or they are extremely sick and we want to take all the work off the body, and that's the way I explain it to families. We want to take the work off the body, so we're going to put the endotracheal tube in, we're going to put them on assist control. I tell families it's the resting mode. So we're resting the pulmonary system because this thing can do everything it can do. Even though you don't notice it, your body's constantly changing your tidal volume, your respiratory rate, and managing that for your amount of really the acid in your blood, or the CO2 in your blood, but it's actually acid. So if we take that work off the body, and that's what I usually tell patient families, we're taking that work off the body with this machine there in the resting mode. And they'll always come and ask me, are they breathing on their own? They're breathing on their own. Right now, we don't want them to breathe on their own because we're taking that kind of work off the body. If they breathe on their own though, if they start their own breath, the machine will finish it each time. We want them doing no work at all. So assist control is the largest one you're gonna see down here. And just so you know, because this is the initial mode we put almost all of our patients on. Don't get too hung up on this one. This is SIMV. This is more of a weaning mode. You may see it down here. This would be a major bonus point if anybody knows what this means. Probably may not even go over to school. Synchronized, intermittent, don't even write this down really. Mandatory ventilation. So SIMV. What this means is we're going to give them a set number of breaths. So we're slowly weaning down. And when they take their own breath, it's just going to give them a little bit of help. It's going to give them a little bit of extra pressure, not a whole volume, a little pressure to help. So they give assistance, partial assistance. That's the best way to put it. So we give them so many breaths. If they take their own, we give them a little bit of help, but they've got to do a little bit of work. So we're allowing them to do a little bit of work, and it's a nice combination between the final mode. So what does CPAP stand for? A lot of people wear CPAPs at home at night, and it's for obstructive sleep apnea. You got that one pressure going in. Continuous positive airway pressure. So it's really similar to the CPAPs at home, but there's an extra little piece to it on a ventilator. So continuous positive airway pressure. We also have, in this case, we have what we call, and it's a little plus, and it says PS. So that's pressure support. So they get a little bit of support, pressure support, is support with each breath. So the difference is that you have the continuous pressure going in. When they take a breath, it gives them a little bit of help to get the breath in. They got to overcome the circuit, the endotracheal tube. This is not their normal airway, so we give them a little bit of help. So every breath, though, in this case, is spontaneous. So they are breathing on their own. We're not giving them any extra breaths. If they stop breathing, the machine knows it has an apnea time, and it will kick into apnea ventilation. Which mode do you think it goes into when it goes into apnea ventilation? AC, exactly right. So it's going to kick back over here and start giving them the volumes again because it says, hey, you're not breathing, you need volumes. So, got that? Questions about that? So these are great. Probably not going to see them down here. That's the big one you're going to see down here. So just because I'm a guy, I like pictures instead of writing all this stuff on the board. So assist control. If we have time and we have pressure here, this is the best way to depict it. So let's say we have PEEP set. So let's see, PEEP is actually in here too. So PEEP is in here too. So we'll talk about PEEP. So let's say that we have 5 of PEEP. And what we're going to do is, this is the pressure delivered over time. So with assist control, it's going to give these breaths like this every time. Let's say our tidal volume is 500. So each time it's going to give a 500, okay? 500 milliliters for each breath. And it goes along like this. And let's say they right here, they trigger a breath. And that's like they're pulling a little bit of pressure away. It's going to give them that full breath each time. 500, 500. And then if it goes so long, it's going to give them another 500. Now that is not the scale. But just so you know, 500 each time with assist control. SIMV. It's gonna look a little bit different. So we have time, we have pressure, we could do time versus volume is probably what we should do. It still looks the same. So it's gonna go along and it's gonna give them the, let's say we have 500 set, and right here they take their own breath. It's gonna give them a little bit of help. So this is the pressure support it gives them that comes along with SIMV. Other than that, they're gonna get 500, 500, 500, 500. If you have your SIMV and your respiratory rate set at 10, they're gonna get guaranteed 10 500s per minute. And then they take their own, they're only gonna get pressure support. The last one is the CPAP and pressure support. So what they're gonna have in this case, you're gonna have your 5 and it's just gonna look like this. When they take a breath, these humps are gonna look like this. They're all triggered by the patient and the tidal volumes are gonna vary by how much they take. So we like this one in the ER because they are resting. Every time they take a breath, it's 500. So family might say, if they can see on the vent, you have 16 set, but they take 18. You say, yeah, they started 2 breaths, but we finished it because every time they take a breath, they get 500. This is how your patients sometimes down here too, if they're not fully sedated, and they start breathing quickly, they can become, they can hyperventilate pretty quick because every time they take a breath, it goes 500, 500, 500. So that's why we really like to have them, if they're in pain or they're not fully sedated, they can get into respiratory alkalosis kind of quick, although those are pretty easy to fix. But every time they get a breath, it's not taking little squatty breaths, they get it finished for them. So, the next thing that we have is, because we have assist control here, so let's say our mode's AC. Next one is respiratory rate. So what's a normal respiratory rate that you might set on the ventilator? Yeah, 16. So respiratory rate, you'll see anywhere from 10 to 20. We always try to keep it an even number. Don't know why, we just always do. So we can set odd numbers. I've seen anesthesiologists set odd numbers. So you're gonna usually see 12, 14, or 6, 14, 16. Let's see. I would say you're usually gonna see 14, 16, or 18 set. Okay, so that's gonna be the respiratory rate. That's gonna be on the machine, I'll show you in just a second. So that's gonna be here, let's say it's 16, okay? The next thing, we do almost all volume ventilation. The only time we don't do it is in peds, and don't worry about that because that gets a little crazy. So, VT is tidal volume, or also, like I said, is TV. And a tidal volume, does anybody know what optimal tidal volume is? There's a number for it. It's actually 8 to 12 milliliters per kilogram ideal body weight, and we like the one low side. Don't memorize that, just remember it's usually gonna be, in most cases, 500 to 800, and that's milliliters. Now on our ventilator though, it's gonna convert that to liters. So you're gonna look at this and let's say if they're on a 700 milliliter tidal volume, how many liters is that? You're at 0.7. Yeah, so it just moves it over, that's almost one over. So it might be 0.7 liters. A little funky looking, you're like, what's going on, 0.7? It's really 700 milliliters. So then you would say 700. So the way it works is really small lady here, really tall guy right here. That's kind of where we go. So you'll see it sitting there anywhere. Now PEEP, positive end expiratory pressure, acronyms galore, of course. So positive end expiratory end. So just for your purposes, this is a pressure that we leave in the circuit and in the patient at all times. And we almost always start with 5 to 8. What this does, it just keeps the alveoli open, because as soon as you put in the tracheal tube in and you pass their glottic opening, you take away what's called anatomical PEEP, which is kind of cool because we all have built-in anatomical PEEP, about 5. When I bypass it with the artificial airway, it goes away. So what we usually do, we just replace it. So 5 centimeters of water pressure, and that's usually what the PEEP is set at. Now, if they're not oxygenating it well at all, we will increase that because that will recruit alveoli. So you'll see 5 to 8. Let's just put 5 here, centimeters of water pressure, and then it could go up if you need more. And then the next thing is oxygen. So when we intubate somebody, if they ever having a hypoxic issue, so they were desatting and whatnot, right off the bat, we would probably start at 100%. If they were not, and it was more like protect the airway type of thing, so maybe they're having some issues with a bleed or something like that, and they need to protect their airway, we'll start with 50%. And then what we'll do from that point is we will wean for their saturation. Okay, so we'll do a blood gas, usually in a half hour. It'll come back, and we may change the FiO2 and take it down. Okay, what you're going to find is, since you guys are new to a lot of practice, over the next 5 to 10 years, we're going to be so much more aggressive with weaning oxygen than we've ever been before, because there's a lot of studies coming out that are showing that this high amounts of extra oxygen in your blood causes free radicals and causes damage. So we've been damaging. We've done in the neonatal world, we've limited it for a long time, but we're going to see way more limit in the adult world. So we're going to be constantly changing their oxygen and getting it as low as we can. Ideally, if they have good lungs, they should be on 21%. And if I put anybody on the vent right now, it should be 21%. You shouldn't need extra oxygen. A lot of times we just give it because it feels good and we should give them oxygen. We don't. You only should give what they need. So what would be a normal saturation that you would want, or a good saturation range? Like a pulse ox range.
90 to 100.
What do you say? 90 to 100, you said?
94 to 100.
94 to 100, so somewhere in that range. Either one of those is good. 90 to 100 is really good. If they're a patient that is chronically hypoxic, like an end-stage COPD, or we might go into the 86, 88 or up, or try to keep them on the low end. But yeah, so 94 to 100, 90 to 100, anywhere in that mid to low 90s is usually good. We usually just don't want it reading 99 or 100. So if it's 99 or 100, 98 or 100, we start weaning the oxygen down. Not something you're going to do a lot down in the ER, but just this is what's going to happen when they go upstairs. So, all right, so let's see what this looks like out on our ventilator.
I know they did an ICU.
So I don't have a test lung on here, but I'm just going to show you how this screen works. We plug it in. Of course, it has to have power on the back of it, and this is all an RT thing, but it's always just really good to know what's going on. Does anybody know what these hoses are for? Oxygen and medical air. Actually, it says air on it because we want to give medical air. So what medical air is it's the air we breathe, but it's been put through a process where it doesn't have dust and it's sterile, essentially sterile air. So that's what comes out of the wall. You have to plug it into the wall. This goes in, and then the machine will work. You can't just plug one in, you have to have both. Because if we just had this in, all we could get was 100% oxygen. This is how, put both of these in, this is how we can wean our oxygen. So both of those plug in to the wall. The machine comes on, and I'm gonna turn it on here now, and you're gonna see this screen. It's not gonna like it because it's not plugged into oxygen, but it's okay. So this is the screen, and this also is the it also is the computer. So it's all kind of involved in that. All this area down here is it used for, this is where all the ventilation comes from. So there can be times, there we go, you can see the screen coming on now. See how it's in color? That means it's coming on. You see how like annoying that got, how it took a while? I don't like that at all. And they knew that happens. So if you ever go to turn this thing off, because if you're like really like me, you're like, come on, you just keep hitting the button. So if you turn it off, this screen will be black and white, which means it's shutting down. So it gives you a little bit of an idea. It'll be the same screen, be black and white. Color means it's coming on. So yes, we want it to stand by. I want to leave it off. Okay, so this will be the best way to kind of look at it. So if you have your patient, you're gonna have some numbers across the bottom and numbers across the side. The numbers across the bottom are gonna be your settings. So in this case, you see some settings on here. So can you all see it? Okay, cool. I'm gonna put some things in here and I want you to kind of, if I was a nurse, maybe I was a nurse up in the ICU, how you would read this. So in this case, let me do some changes here. I'm just gonna make it real funky. Okay, so first person, how would you read, what's your name?
Jamie.
Jamie, okay, Jamie, thank you. Jamie, how would you read those settings to a nurse upstairs? So first of all, how do you want to look at the way that you're gonna read it? I'm gonna leave them all in assist control, just so you know that I'm not gonna jack with that. And how do you know that? It's right here, VCAC. So it's called Volume Control Assist Control. So my patient's currently in
AC.
assist control.
Yeah.
Yep.
Respirations are 17.
Yep, good.
Tidal volume 350.
Good.
That keeps at 8.
Yep.
And oxygen says 55.
Exactly. And if you say it like that, that's perfect communication across the board. So it will help you a lot, because what happens, a lot of people do is they go through this and they say FiO2 is 55, tidal volume is 350, TI is 0.94, and that's what you were asking about, the TI. We don't even give that in a report. It's something that we manipulate to how fast the breath goes in. The nurses upstairs and you guys don't even care about that stuff. So it's just an RT thing. Respiratory rate and then PEEP. So you can see how they're like, okay, all this stuff you're giving me, it doesn't fall into this normal reporting mode that we're used to, okay? All right. We try to keep them even numbers too. All right, your turn.
Okay. So AC, the rate is 20.
Mm-hmm.
Tidal volume is 510.
Mm-hmm.
PEEP is 6, and oxygen 65.
Great, perfect, exactly right.
I didn't memorize that for a little bit.
Yes, I mean it does take a little bit of time, but it's something I don't believe we teach it in nursing school. So barely, yes.
It's in med-surg 3, and then it's like a paragraph.
But it's a good, I mean, communication is what it's all about once you get in the hospital, and as long as you're communicating on the same level. So
assist controlled, respiratory rate's 14.
Yep.
Tidal volume's 600.
Yep.
PEEP is 8, and oxygen is about 69.
perfect. All right. You feel good about it?
It's gonna be hard to see.
Yeah. Okay. Well, I won't do yours then. I won't do yours then. So, if you're gonna write it, this is the easiest way to write it too. So, when I call a report to somebody, they're an AC of 16. So I just say AC of 16. No, I'm saying respiratory rate. So, AC 16, 700, 5, and let's say 50%. And that's what we'll report out. If they're on SIMV, I'm just gonna give this to you, but don't have to remember it. There's gonna be another number right here in this X position, and that's our pressure support. Don't worry about it. They're gonna be assist control down here. Okay, we wanna keep it pretty simple. So, assist control, rate of 16, 700, 5 a PEEP, and 50%. That's exactly what they're gonna be looking for to know. They may ask you how many breaths is the patient taking on their own? Maybe not. What's going to happen over here on this side? Probably they ask that. That's a good though. So there's two ways to get their total respiratory rate. One is the monitor. The other one is the vent. Which is more accurate? Always vent. Monitor is just from a chest lead. So on the side over here is going to be a bunch of values, and you're going to have total respiratory rate. It's going to be over here. This is patient values. Across the bottom is your settings. So if you're reading settings, you're looking across the bottom. If they say, what's the patient values? You look over on this side and you say, well, the vent right now is saying they're breathing at 18. Okay.
So if that's high, we need to do something.
Not always. Not always. I mean, if it's 20, greater than 20, I mean, we don't want to do that for a long period of time. So they may ask you, but if somebody's breathing, if they're on assist control and your endotracheal tubes in the right spot and they're breathing too much, how are you going to slow their breathing down?
Right.
Yeah.
Yeah.
You're going to use analgesics, paralytics, or sedatives. They're not really in that order, but you're going to use one of those things to kind of help them. Analgesics after you get in will help quite a bit, especially if they were in pain. Because has anybody intubated before? Personally, well, sometimes if you've had surgery, they probably put an LMA in, which is a laryngeal mask airway. It doesn't go all the way into your trachea, it just goes at the top. So you could have that if you, and that's when you wake up with a really dry throat, but it's not a normal feeling, let's say that, to be intubated. So
Yeah, EMS will bring them in on LMAs sometimes.
LMAs are great. So my little thing about LMAs are really great for codes. So for coding somebody, you have an LMA and it's a good airway. But if we get them back, we have to pull that out because they cannot go on an LMA on the vent. They've got to have a tracheal tube in. Now, if you're late in your code and you're going through your H's and T's, and the last thing, and you really can't find the cause for this, then we really want to think about securing the airway. When we say secure the airway, we're talking about putting an endotracheal tube in. So we could do that later in a code when we checked off all of our H's and T's and we're down to those ones where you're like hypoxia, that's going to be a tough one, and those other ones that make sure you have a secure airway, we'll put an endotracheal tube in. But you can do a straight code with an LMA, just fine. Once you get them back and you get to ROSC, we have to go and put a tube in because they do put people with LMAs on ventilators in surgery, totally different situation. Sedated, paralyzed, you're just a big chunk of meat right there and they can do whatever they want with you. So that's the way I kind of think of it. Your patients are not going to be like that. All right, cool. So let's talk about BiPAP real quick because that's another one, and then we'll do some blood gases. So does anybody know what BiPAP stands for? Has anybody ever been on BiPAP? I think a prerequisite for anybody taking care of someone on BiPAP, they should have to wear it because it seriously is, it's a different world. So this bi means two, and this is positive airway pressure. So there's two airway pressures. Our machines can either do BiPAP or CPAP. Remember I said with CPAP, that's continuous positive airway pressure. That's one pressure. What is CPAP commonly used for? What disease processes? Sleep apnea is the biggest one, is especially OSA, which is obstructive sleep apnea. They have central sleep apnea, that's a different problem. It means their brain stem's not telling them to breathe. A lot of people do have that. And then another one you'll see CPAP used for is for somebody with a straight oxygenation issue or like a CHF type issue. So with CHF, they have fluid coming into their alveoli, and we need to kind of push that fluid down. So let's say with CHF, now this is very generic. So we have our alveoli, we have our arterial blood flow. With congestive heart failure, you have backup of fluid, increased oncotic pressure pushes over into the alveoli. They start saturating poorly. They have crackly breath sounds, which means their alveoli are opening each time you do it. So what do we do to help them? What's the thing that we give them? Medication-wise, Lasix. We give them oxygen, we give them Lasix. So we give Lasix, we give Bumex, some type of diuretic to help get fluid out of here. And so we decrease that, the pressure changes and it comes back across. We give extra oxygen going here. The one thing that helps a lot, which we don't see done a lot, is giving CPAP. So you add that continuous positive airway pressure, it goes in here, it pushes this fluid, and actually offsets that pressure and pushes the fluid into the bloodstream, so it makes your diuretics work even faster. So it's something that can be used in ER, and sometimes is, but using CPAP to offset just a straight fluid issue is really important. So OSA, oxygenation issues, usually with some kind of pulmonary edema, related to congestive heart failure, common for CPAP. BiPAP is the one you're gonna see most often. Now, if any one of y'all came in and you had a really bad pneumonia and you had an oxygenation issue, but there was no ventilation component, like your CO2 is normal, the best remedy for that would be CPAP, because it's just an oxygenation issue. But we don't do that. We put people on BiPAP every time. So BiPAP has the 2 numbers, and I'll draw a picture in a second to help make sense. It has 2 numbers, and it does oxygenation, helps with that, and it also helps with getting rid of CO2, which is ventilation. So it helps with both aspects. Most of our patients that come in have some kind of ventilatory issue because of a long-standing COPD. So, draw a picture, easy enough, time and pressure. This is for CPAP. So let's say we have a CPAP set of 6. We look at our pressure on this. You'll have these little humps in here, but these are just the patient taking a breath each time. This is a continuous pressure going on, and I like to think of this is your area for oxygenation, right in this area right here. So CPAP, it can do that. BiPAP is a little different. We're gonna set 2 pressures, and let's just say our top pressure is 12 and our bottom 6. So we're gonna do 6 and we're gonna do 12, and what BiPAP does is it goes along and then it goes up to 12 and it goes down, up to 12 and goes down, up to 12 and goes down. So, and this is the patient taking a breath every single time. So the best way to describe BiPAP is we're augmenting their spontaneous tidal volume. If Jamie has a patient and they have a respiratory rate of 6, BiPAP's not a good option for them, although sometimes it gets ordered for them, because they have a respiratory rate problem. They need something that's gonna affect their rate, which is a ventilator. This only augments their own spontaneous tidal volume, so long as your patient has a good respiratory rate, which is a lot of our patients fall into that. But if somebody takes too much medication and their respiratory rate is falling, a BiPAP is not going to do the job, because the BiPAP mask can actually fluctuate. It will trigger and fluctuate on its own, but you have to have mechanical movement to get the air in. The patient has to make some effort. So with BiPAP, we have this area of oxygenation, but then we have these areas, these tall towers of ventilation, or getting rid of CO2, okay? So that's how we decide which one to put them on. A lot of patients don't like CPAP, so we'll just put them on BiPAP. If you came in with a pneumonia, BiPAP feels a little bit more normal for a patient when they're breathing, because you'll hear when you walk in the room, you don't have to see the BiPAP, or you don't have to see the CPAP unit. You'll walk in the room and you'll hear shh, shh. They're on BiPAP. There's 2 pressures there. If you just hear this one, that's CPAP. You can hear it. That sounds almost exactly like that.
Know those alarms.
There's some little piddly alarms that'll come up. We call them yellow alarms, but then there's red alarms. And how you're gonna know that with this Draeger is on this bar right here. It's really the cool thing about it is that 360 degrees. So if this is facing the patient and you can't see it at all, this will come up red on this line right here. So it's really good for ICUs when you have a lot of ventilators and you hear one going off and you're like, which room is that? All the nurses have like a 6th sense up there, so they know exactly which room it is. But if you walk by and you see red on this, that's a red alarm, and needs something done about it right now. So the number 1 red alarm, like Heather was saying, is occlusion of the tube, or high pressure occlusion tubes are biting down. And another red alarm, of course, is low pressure, which means they popped off. So either one of those situations, you're usually going to, and this is the best thing to do, you're going to call a respiratory therapist. But in the meantime, number 1 way to bypass this whole machine is to hook them up to a back valve mask and give them a breath through the tube. Then if they fight it, you can just kind of wait, hold pressure, they're coughing or whatever they're doing, and then once they let up, you give them the breath. So we would much rather show up, the respiratory therapist, to a room where somebody's just ventilating patients, and you would say that vent was going crazy, some red alarms and stuff, so I just took them off and bagged them. That is the absolute smartest thing to do. It doesn't happen all the time. A lot of times people are like, well, I remember this class Jimmy told me, he taught us this, so we can kind of change some stuff in here. So yeah, don't jack with the machine, because there's so many things that you can change with the machine that won't make any difference at all. So it's kind of confusing. We like buttons. That's the technology aspect of this generation, is we like changing things. The best thing to do is take them off, hook the bag valve mask up to 100% oxygen, and just ventilate them. Because it kind of
suction them, because I notice like a lot of times it's just they need suction.
Yeah, a lot of times they do need suction. So I can show you something. You can suction down here, right?
Yeah,
Inline
so
suction.
the suction
You
button.
don't have to have
Yeah.
respiratory suction.
No, we don't. No, you don't. You don't. So there is a cool button on here, and if I hook this up to air and oxygen, I can show you. But this button right here, let me pull a little closer. It's a soft key, and it says O2 suction. It's in the same place on every one of these. So with this machine, every time you touch something, you see it turns yellow, this thing lights up. So you see it goes away. When I touch something, it's like, are you sure you want to do it? To confirm it, you push the button in each time. Touch, adjust, confirm is what it is. Touch, adjust, confirm. So with that oxygen button, it's the same way. You touch this button right here when it's highlighted, or like, let's say it's like this one, and then touch and confirm. And the oxygen button is really cool because what it does is silences the alarms, but then it gives them, it pre-oxygenates them like we're supposed to do, right? To prevent any kind of ectopy. So it pre-oxygenates, silences the alarms for us. It's really important if you hit that button and you go to suction, and you suction, you come back, and that's just fine. But let's say you are called to, you go to suction them, and somebody calls you away and you don't suction them yet, the machine's waiting for them to be suctioned. In other words, it's waiting for them to be off the vent because it senses them being off the vent when you suction because you're pulling the volume away. So if you go to the O2 suction button and you hit it and then you walk away without resetting it, then pop off the ventilator, it won't alarm. So that's one real key. If you use the suction button, make sure you suction them, okay? It's extremely rare that would ever happen, but it's just something I always talk about when we talk about that button. But it's a great button for that. And the button below it says manual, inspiratory, and a hold. You actually can hit this and it gives them a breath. It's like bagging them, like giving them extra breaths. So the other ones you probably won't deal with that much. There's a silence button right here, and it will alarm loud. So what I recommend is when you come into the room, you start looking at your patient, how do they look? You come over to the ventilator, and in the meantime, you hit the alarm silence button. It's not gonna make the alarm go away, but it just stops it from being in your ear and helps you think a little bit. So it's a hard key right there. It will silence it for 120 seconds. Now, if let's say they have one alarm and you hit this and something else alarms, it will alarm over it. So it only silences the one alarm going off at that time. So silence, O2 suction. It's the main buttons you're gonna use. So let's say we have a patient and they come in and it's a COPD patient that we've had many times before, and we know their CO2 is usually high, and they come in and they've been short of breath at home for many days, and now their respiratory rate starts to slow, and let's say the respiratory rate's like 8. What would you recommend? We're gonna go with a BiPAP, or we're gonna go with a ventilator?
Ventilator.
I got mouse first to assist breathing. Then
You could, yeah, you could say both actually. You could say put them on a BiPAP while we get the vent ready, type of thing. But remember, if it's a rate issue, we're gonna want to go to a vent. Now, if they came in and they had an accurate rate, let's say they're breathing 20 times per minute, but their CO2 is still high, the first thing we're gonna try on those patients is gonna be a BiPAP, because we'd rather not put them on the ventilator if we can get around it. And there's many times where we can get them over the hump of this exacerbation and never put them on a vent. Okay, so it's really important. So let's say I give you a blood gas. Okay, so this might have to knock the dust off it a little bit here to remember how to do these. So when you write these like this, it's just like that ventilator settings over there. It's a shorthand. It's pH, PCO2, PO2, and bicarb. So, what's the problem with this patient?
The
Acidotic.
Acidotic, that's absolutely the first thing. Yes, they're acidotic. How do you know they're acidotic?
Well, their pH is low,
pH is low. What's
First
normal? What's normal for pH?
7.35 to 7.45.
Right. Okay. So yeah, it's on the low side, so they're acidotic. So what's causing the acidosis? What else is out of range?
The PCO2.
PCO2, which, what does that mean? Does that mean it's a metabolic issue or a respiratory issue? Respiratory issue. So, what's normal for PCO2?
35 to 45.
Easy way to remember that. You know the pH, you know the CO2. It's the same thing. So, it's high. Acidosis. So this is a respiratory acidosis. PO2 is with the normal limits as far as if they're on room air. That's key. PO2 changes a lot of non-room air. And what's normal for your bicarb?
22 to
Yep. 26. So good job. I put it right in the middle. So that's normal. So this is a respiratory acidosis. This is an uncompensated respiratory acidosis. Now, if you're in school, we got to know that stuff right off the bat. But in the clinical case, we just need to know they're acidotic. It's causing from the respiratory system. How can we fix this patient? Put them on BiPAP. Because what's BiPAP going to do? Why not CPAP? Why not CPAP?
Because you want, it's probably more of a, because the CO2 is high, you're gonna wanna blow it off.
Yes, you're going to have something that's going to help their breath. They're augment their own breath, so you need something that's going to help with CO2. So yeah, this is going to be definitely a BiPAP patient. So let's say we put this patient on BiPAP, and we put them on BiPAP, and we'll say 12 over 6, so just like that graph that I had. And we always put a backup rate on them, but we try to keep the backup rate low, and I'm going to say is 8, because I really don't, all I want the backup rate to do is if they get to that point, or like if it's 10 breaths per minute, a breath every 6 seconds, I want it to alarm so we know that they're down there. I really don't want them breathing off the backup rate because that's not good. So let's say I did BiPAP 12 over 6, I wait 1 hour, and now I have this blood gas. This blood gas 1 hour later. Is it within normal limits? No. Acidosis or alkalosis? Acidosis still. What's causing it? Respiratory. It's a respiratory system. Is BiPAP, so here's your question, is BiPAP working? Minimally. It is, but it's minimal, not much. I mean, that's an hour later. I'm not really super happy about that. But we are showing a decrease in CO2, which is really good. If this CO2 would have been 50 or higher, you got to go to that, dude. It's just, hey, we failed. It's called failing the BiPAP. So it went down, not a lot, went down a little bit. So bicarb's coming up because that's what it will do. It moves really slow. So what might you recommend now? Let's say we want to keep this patient on BiPAP. What might you recommend now? Change the settings, yeah. So what setting would you change? Now this is kind of hard. What setting would you change? Would you change to 12 or the 6? Nope, it's actually 12. Remember the 6 is that baseline for the oxygen? If you change the 12 and increase it to 14, you'll have taller peaks, and that gives you more area to get rid of CO2. So that's good. It's really good thinking though. So we change the BiPAP settings, and we make it 14 over 8. Now this is what I'm just telling, this is like maybe a little deep, but this is what the RT's thinking. I want to increase those. So then we get 7.35. And these are all made up gases, but you get the general idea. So we get back to this point, we're on the outer limits, but this is considered normal. So this is a normal blood gas. This is where we would like them to be. So we've kind of overcome this exacerbation of where their CO2 is risen from putting them on a BiPAP. Cool. So let's say we go back have this blood gas. This is gonna be pretty poor. And you can't always just look at the numbers and say, oh, they're gonna be on a ventilator or they're gonna be on a BiPAP. Okay, let's say, okay, this is a pretty bad one. 715, 95, 60, and 20. So, first of all, the acidotic, pretty bad acidotic, right? What's causing it? Respiratory and the metabolic side is too, because that's low too. So this is a mixed acidosis. Anytime you have a mixed acidosis, it's usually, if they haven't coded yet, they're going to. And so this could be recovery after a code. So let's say we have this blood gas, and in this case, they're pretty sick. I probably wouldn't go with a BiPAP with this, so let's go with a vent. So I'm gonna give you some vent settings. So, system control rate is 16, 600, 8 of PEEP, and 100%. Let's do another blood gas. 1 hour later. Our blood gas 1 hour later. So is the ventilator helping? Just kind of a generic question. Yeah, because our pH is coming closer back to normal, right? It's not got them back to where they need to be yet, but what do you think about the CO2? It's come down quite a bit. What might you recommend, or what might you expect the physician to give you as a change on their ventilator to help get rid of more CO2? Because you've got rid of a lot, but you need to get it closer to normal if you can. What do you think that the physician would change? Because here's your settings. Absolutely. The fastest way is to increase respiratory rate. So always in the ER, that's what you're going to be doing. You could also increase their volume you give them, but the fastest way is going to be respiratory rate. Yes. So they're probably going to give you an increase in respiratory rate because right now, although it's working, an hour later, you should be able to get them back to normal. You should be able to get them back to normal within 30 minutes on a ventilator. Okay. So increase respiratory rate because that's what they need right now. So that would be a good thing to know is if your patient came in assist control and you would tell the nurse upstairs or whoever you're going to report to upstairs, oh yeah, we'll look at the oxygen, but you were telling whoever upstairs and you said, well, initially put them on a rate of 16, but they came back and they were still acidotic, so we upped it to 18. Because they may ask you, wow, 18, that's kind of on the high end. Well, their gas came back acidotic after they're on the vent. It's always good information to know and report. What about the 350?
That's their PO2.
Yeah, I'm sorry. That's their PO2. So what about it? I mean, normal's like 80 to 100 on room air. We're giving them 100% oxygen.
So you decrease the oxygen.
We could decrease the oxygen. So interesting thing about PaO2 is if I put any one of you all on a non-air breather right now, and that will be 100% oxygen or close to, in about 15 minutes, your PaO2 will be about 600. And what that means is just extra oxygen that's dissolved in your blood. It doesn't do much for oxygenation, but just kind of gives us a good idea about your oxygen. So yeah, in this case, I would probably take this 100 and we'll probably just cut it in half right off the bat. Just go to 50. That's usually what we'll do. And then we'll kind of titrate it to keep their saturation. Now, I didn't give you a saturation. So let's say in this case, their SpO2 with 100%. Would you kind of expect that? So then that's where we're going to start decreasing our oxygen on our patient. Okay.
So that PO2 is going to be a lot more accurate than just what you're seeing on their finger there. Because the highest that can go on your finger is 100%.
Mm-hmm. Yeah, but and then the most important aspect of it too, this is a good number, but the most important aspect is if you are binding oxygen and hemoglobin. So that's important about getting to your tissues. But I have a YouTube video on that if you want to like put you to sleep some night. Get my oxygenation YouTube video, and I explain the difference between PaO2 and bound oxygen or saturated oxygen. And I use some equations and stuff, but it'll make sense to you, and then you'll know why your patient that has GI bleed has a low hemoglobin, even though they're setting 100, they're actually really hypoxic because they don't have the hemoglobin to get it to their tissues. So cool.
I think that's good.
I think that's good.
Yeah, you're right at time. Hannah